Haq in the session 5 Shurma. Our topic is Echo in Intervention. In this session, the chairpersons are Professor Kumar Chowdhury, Professor M. Zahid Hossain, Professor Fazila-Tun-Nesa Malik, Professor Khondokar Qamrul Islam, Dr. APM Shorabuzzaman, Professor AQM Reza, Professor Emeritus IB Vijayalakshmi, Dr. S. Sivakumar, Dr. Amitabha Chattopadhyay. The panelists among us are Professor M. Badiuzzaman, Professor Tariqul Islam, Dr. Kaiser Nasurullah Khan, Dr. Kajal Kumar Karmokar, Dr. Pradeep Kumar Karmokar, Dr. Mohsin Ahmed, Dr. Mohammad Shafiqur Rahman Patwari, Dr. Khondokar Asadujaman, Dr. C.M. Shahin Kabir, Dr. Abdullah Al Shahriar. In this session, we are honored to name 3 presenters. World-renowned Professor I.B. Vijayalakshmi, Dr. S. Sivakumar, and Dr. Amitabha Chattopadhyay. In our cardiology community, they are very famous and loved. We are always looking forward to hearing from them. Now I am handing over to Dr. Mustashirul Haq to conduct the presentation sessions. Thank you.
Thank you very much, Dr. Jafrin Jahan. I am Dr. Mustashirul Haq, Assistant Professor, Bangabandhu Sheikh Mujib Medical University, and my co-moderator for this session, Dr. Jafrin Jahan, Associate Professor, National Institute of Cardiovascular Disease. Welcome to participate in Home and Abroad International Virtual Eco Summit 2020. So, my 3 speaker, a renowned pediatric cardiologist. First of all, Professor Emeritus Vijayalakshmi. She is Professor of Pediatric Cardiology, Sri Jayadeva Institute of Cardiovascular Science and Research Institute, Bengaluru. She is MD, gold medalist, skilled interventionist, pioneer in pediatric cardiology, a brilliant academic career, and secured 22 gold medals and 52 publications, more than 100 scientific research, and delivered more than 200 scientific lectures. Authored step by step to echocardiography in congenital heart disease and a comprehensive approach to congenital heart disease. I would like to request Madam to share your screen and deliver your talk. Thank you very much.
Good evening, everybody. Are you able to see the screen?
Yes, ma'am.
Okay.
Yes, ma'am.
Yes, madam. Yes, they are audible.
It's always a pleasure to be with Bangladesh cardiologists, and I'm missing the lovely company of you people. However, I'll speak about the echocardiographic evaluation in congenital heart disease, basics and beyond. The diagnosis of cyanotic congenital heart disease represents the epitome of clinical logic and correct inferences from accurate observations, the diagnosis with gratifying frequency. That's what Joseph Parlap said, and that is his autograph I got 30 years back when I was a student, and now for my book he has written the preface, and he was a great person. Now you know the classification, simple AST, VST period, you all know about it. The rare complex, I remember 5 T's and 3 A's and 2 E's, and miscellaneous are DORV, DOLV, single atrium, single ventricle, those are the things. Now starting with the basics, you all know the basic views, but in congenital heart disease, we give importance to the subcostal view, and then we have to go to the right side for the dextrocardia and also right parasternal, and one space above the short axis, that is the ductal view, and also the suprasternal view. So these are the extra views that we take care in the congenital heart disease. Now when you start the basics, you have to start with the segmental approach. If we don't have the segmental approach, our diagnosis will collapse like this. And hence, remember, sequential echocardiography, the venous segment includes both systemic and the pulmonary veins and the coronary sinus. The great veins are systemic, superior vena cava, LSVC, inferior vena cava, and hepatic vein. Coronary, we have the coronary sinus. Pulmonary veins, we have 5, not 4. And then veno-atrial connections also have to be taken care of, and atrial segment also should be looked for, and the morphological LA-RV should be looked for. If we miss the segmental approach, we will miss the diagnosis. As you see here, this is the dilated LA and the LV. And what do you see here? The superior vena cava is draining into LA. So this patient will not have anything otherwise, but the child will have cyanosis and will miss the diagnosis if we do not see where the superior vena cava is draining. When we come to the inferior vena cava, it is visualized very well, and especially when it is dilated and the spontaneous echo contrast is seen, we have to be very careful. And the bicaval view is the best in the transesophageal echocardiography, where you see both the SVC and the IVC in a one plane. So in subcostal view, you have to look for the aorta and the IVC. And normally, in the situs solitus, aorta is to the left and IVC is on the right. But in the situs inversus, it is reverse. Whereas in situs ambiguous, we are not able to make out which side it is. So in such cases, you have to go beyond, and computed tomography can tell you that this is the CT angio in the situs ambiguous, mesocardia, interruption of the intrahepatic IVC with hemiazygous system, and the RSVC and the LSVC both draining into LA. And these are the things, and also with the polysplenia, and all these things can be made out in the CT. So we have to go beyond the echocardiography. Whenever the IVC is dilated, the SEC is there, and we have to look what is the cause for it. And the usual causes are pericardial effusion with tamponade, constrictive pericarditis, restrictive cardiomyopathy, and right ventricular dysfunction, and RA thrombus, and also the aortoventricular AV fistulas. Whenever the SEC is there, you must think of the impaired flow into the stasis or the membrane obstruction. And you can see here that this patient was cyanotic and had a DORV. In a case of DORV, on top of that, there is a massive pericardial effusion with the mesothelioma attached. So in congenital heart disease, never be happy to make one diagnosis, and you have to look for the other abnormalities. When we come to the basic subcostal view, you can see that this is how you see the structures, and this is the best view for looking at the atrioventricular septums. Now, when you look at here, you can see that if the apex is to the left, it is levocardia. It is to the right, it is the dextrocardia, and if it is in the middle, mesocardia. If it is a mirror imaged dextrocardia, the LV will form the apex. If it is isolated dextrocardia, the RV will be forming the apex. So this is how we identify the site. And then when the parasternal long axis, this is how you can see all the structures. And here the mitral to aortic continuity has to be looked carefully, and the interventricular septum has to be looked very carefully here. So here you can see that when you see the segmental approach, the LV is draining into the pulmonary artery, that is which is a branching vessel, and the RV is going into the aorta, which is the arching vessel. So this is the TGA. So this is how, when you go to the segmental approach, this is how you can make out. And here you can see that mitral to aortic continuity is not there. There is the thick ridge indicating that this is the pulmonary artery, and you can see that pulmonary stenosis is there, turbulence is there. So this is the DORV. So in the parasternal itself, you can make out the difference. So clinically, we make the aortic regurgitation, but then echo can tell you what is the cause for the aortic regurgitation. You can see that here, aneurysmally dilated cusp is prolapsing, causing the aortic regurgitation. So the MOR can make out that. Apart from that, in the parasternal long axis view, you can see if there is an annular dilatation, ascending aorta dilatation, or the ascending aorta is narrow. All these things can be made out. Then in the hypertrophic obstructive cardiomyopathy, speckled appearance of the spectrum as well as the SAM can be made out. And here, especially when you take the MOR, the SAM is very nicely seen, and premature closure of the aortic valve. You can see that how it is fluttering and closing. Normally we have the box, and here it is the premature contraction. This is the typical hypertrophic obstructive cardiomyopathy. In the same parasternal long axis view, you can also see the supramitral ring as well as the divided left atrium, that is the quadriatrium sinister, and whether it is fenestrated or not can be seen. But now we have not only the 2D, 3D, in the 4D echo here you can see that on the RA side you have the coronary sinus, on the LA side you have the membrane, and this is how the 4D echo looks exactly like that. And in the 4D echo itself you can see that this divided right atrium or quadriatrium dexter is not fenestrated and it is intact. So in this patient I have done the balloon rupture of this membrane to relieve the congestive cardiac failure in that patient. So we have to go beyond to make the diagnosis and give the best treatment to the patient. So this is the subaortic membrane, and many times subaortic membrane is missed. If it is very close to the aortic valve, you can see that the cusp is away from the membrane, and now it is known that this membrane can grow over the period and it can become like a tunnel, and this patient had a tunnel like subaortic membrane, the gradient of 170, so this had to go for the surgical resection. Nowadays we don't do the balloon dilatation for the membrane, they all go for the surgical resection. This is the apical 4-chamber view. In the apical 4-chamber view, we see all the 4 chambers very well, and interventricular septum becomes the part of the LV. And here you can see that when there is a RV dysfunction, it becomes part of the RV. So this is the large AST that you see. This is usually the pediatrician, they invert the image, and this is how you see. In the transesophageal, you can also see whether the rims are adequate or not, and this is how in the adult we do that. And now beyond, if you go intracardiac echo, that is ICE, is an invasive one, and this is the probe in the right atrium, and while doing the large AST closure, the intracardiac ICE is done. Where I was trained in Chicago, Hijazi was using this, but this is expensive and it is not possible in our country. Gone are the days when we used to see this device in the autopsy, whether the endothelium has gone. But today we have the 4D echo. You can see that instead of giving 3 months, 6 months aspirin after the device closure, we can do the 4D echo, and how beautifully the whole device has become endothelialized, and that's how we can decide whether aspirin to be stopped or not. So AST, we were wondering how to measure the rims, but now we have to see whether the size is all right or not. In the 4D echo, we can see from the RA side as well as from the LA side, and not only that, we can also make out the shape of it, the size of it, and whether it is a small, large, because many a times after putting even the large device, there may be a portion of it where there is a residual shunt because of the shape of it. So this is a 10 months old baby and a very rare condition. And I was wondering what it is. I thought it is a non-compaction at the apex and the Swiss cheese VST, and then I was not able to make out the 4D. So with the 2D, I sent for the CT, and in the CT we could see that there was a double-chambered RV and highly trabeculated, and then they gave a doubt whether there is a VST or not. Now, since the child had pulmonary stenosis, and I wanted to make sure, because if I open the pulmonary stenosis with the balloon, the VST might become worse and then the pH may occur. But look here, the non-compaction Samir was describing, and the non-compaction is so beautifully seen in the 4D. You don't require any criteria, and the double chambered, and you can see that interventricular septum is intact. So I went ahead and did the balloon dilatation of the pulmonary stenosis, and now the child is 2 years old, and this is the mitral valve, tricuspid valve, and that is the interventricular septum, which is split, but there is no flow across it. And this is how you can see that interventricular septum is intact, and this was not a Swiss cheese, it is a double chambered right ventricle with the pulmonary stenosis. That's how when we go beyond, we can make the decision with more precisely. So this is the triology of fallow, a tight pulmonary stenosis with the PFO and right to left shunt. With the severe TR, with the balloon dilatation, the child improved. So this is the apical 4-chamber view, And I showed you in the apical fourth chamber view, classically the tricuspid valve is more apical, and here you can see that the more apical tricuspid valve is on the right side. So this is the morphological RV, and as a result, this is the corrected transposition of the thing with the VST. So in the apical fourth chamber view, you can also see the whip-like movement of the anterior tricuspid leaflet, and the septal leaflet is adherent to the interventricular septum, and this is the Epstein's anomaly. And in this Epstein's anomaly, you can clearly make out the RV, atrialized RV, as well as the RV itself. And here you can see that the overriding of the aorta is there. Overriding of the aorta is there, and the large subaortic VST is there, and you can see that the annulus is very narrow and the bud-like valve is there. So this is the absent pulmonary valve with the free pulmonary stenosis and the pulmonary regurgitation. And this is a special subset of tetralogy of Fallot where it is absent. We must also look for the absent right pulmonary artery. You can see that the right pulmonary artery is absent, and here you can see that the left pulmonary artery is absent, and that is called as the Dubuque syndrome. And this is a different cup of tea for the surgeon for the correction. This is not like a regular intracardiac repair. In such cases where the pulmonary atresia is there and the multiple aortopulmonary collaterals are there, the best thing is we have to go beyond and get the 3D reconstructed image of the CT angio to make the unifocalization. So here you can see that there is what appears like the ostium primum AST, and in fact it is the dilated coronary sinus, that is the intracardiac TAPVC. So you have to look where the pulmonary veins are draining, and that is the inverted image along with the confluent chamber in the behind the LA. So this is the supracardiac TAPVC. You can see that in fact the figure of 8 is explained in a case of X-ray, but in an echo itself you can see the 8 figure. So beautifully you can see the vertical vein, horizontal vein, and the superior vena cava, and this how the figure of 8 can be made out even on the echo. So whenever there is a ground glass appearance in the X-ray and the child is very sick in the neonatal period, you must look for the infradiaphragmatic TAPVC, and here you can see that there is a turbulence and the continuous flow in the hepatic portion of the IVC, indicating that there is a infradiaphragmatic TAPVC which is obstructed. And the complete AV canal defect itself is a chapter, and last month I had spoken to the Bangladesh cardiologist, and this is a very important thing that echo can make out. And post-operative evaluation also is better than with the echo. So this is a patient where the patch is given, and you see the background patch is adynamic, whereas the interventricular septum is dynamic. So this is moving very well, but the patch is not moving, and the patient has got the aortic regurgitation in the diastole and the residual VST during the systole into the RV. So the two jets indicate that one is the residual VST and other one is the AR, indicating that the patient requires redo surgery. In the short axis, we have to look at the two papillary muscles, and this has to be done very carefully in the pediatrics. If there is only one papillary muscle, that indicates that there is a parachute mitral, and this is attached to the apex. So whenever there is a parachute mitral, you must look for the supramitral ring, and also look for the subaortic or the supraaortic obstruction, and apart from that, coaptation of aorta, and this is called as the Schoen's complex, though rare. And one thing that you must remember, that in congenital you have to look for all the abnormalities. So this is the single ventricle, and you can have the single ventricle with the double inlet single ventricle, that is the LV type, and that can be seen in the short axis. In the tricuspid atresia, you can see the inverted image also, the LV function and the AST and the VST and the gradient all can be made out with in the tricuspid atresia. In the apical fourth chamber view, you can see the overriding in tetralogy with the pulmonary stenosis. You can see the supraaortic stenosis with the gradient that is in the Williams syndrome. So apart from 5-chamber view, then you have to go to the short axis. In the short axis, this is how you look at the RVOT and the pulmonary artery and the branches and the aortic valve. And the bicuspid aortic valve is the commonest congenital heart disease. The slit can be horizontal or vertical. You can have a quadricuspid valve also. In the short axis, normally it is a cup and saucer-like thing. The cup is the aorta and the saucer is the pulmonary artery. But whenever there is a DTGA, you have the side-by-side aorta and pulmonary artery at the same level called as the owl's eye, and you get like two rings like this. And if there is a malposition, there can be anteroposterior position. So the pulmonary artery and the aorta, there may be malposition may be there. And in a single coronary ostia like that you see here, in an infant and the newborn babies, the coronaries are very nicely seen, but when you go to the bigger children, it becomes difficult, and the coronary anomaly constitute 10 to 12% of the pathologies, and if this anomaly is not told, the surgeon can cut while doing the infundibulectomy and get into trouble, and hence we go for the CT picture, the reconstructed image, and you get beautifully all the varieties of the anomalies that you see. In the same short axis, you can see that the AP window can be diagnosed very well, and after the device closure, the echo also helps in making out whether your device is in position or not. So in the suprasternal view, many times the picture is not very clear, and here again we have to go beyond to see the reconstructed image, and here you can see that from the pulmonary artery, the duct is continuing as the descending aorta in the interruption of aorta. So we have to go for the ductal view one space above to make out the ampulla, the length, and before deciding for the device closure, the proper assessment is very important. Associated TGA with pulmonary stenosis, and here you can see that the bidirectional glen that is done also can be made out in the echo. So this is the inverted image, and this is the patient with the TGA with the PAPVC. So this is how even the complex congenitals can be made out. Here you can see that it appears as if it is a double aortic arch, but it is not a double aortic arch. It is the tunnel is there. This is the right coronary artery, and just by the side is the tunnel. So this is the aorto-right ventricular tunnel, and with the single coronary ostia, and as a result, it was easy for me to do the device closure, and at the end of the tunnel, you can see the device beautifully sitting without any residual shunt. And this is the aortic atresia, extremely rare, 0.03% of the time, but gone are the days when we would make the diagnosis after the birth and struggle, and this now we can do it in the fetal echo itself. Even ectopia cordis can be made out very beautifully, and all the conditions where the medical termination of pregnancy has to be done can be done with the fetal echocardiography. Now I'm able to diagnose the fetal echocardiography, the most of the things very well. And the most recent one is the blood speckle imaging. And here, this is one where we can make out that I'm finishing, sir. So here the RV function is very important in children, but this was not possible. Now with the 4D echo, RV ejection fraction can be made up. To conclude, in the last 5 decades, echocardiography has evolved into most useful and non-invasive, cost-effective diagnostic technology in the management of congenital heart disease. From M-mode to 2D, 3D, 4D, Doppler, color Doppler, transesophageal, intracardiac, fetal echocardiography, the journey has been fascinating and rewarding, which has made us look beyond the basics. And this is how it looks, the 2D, 3D, and the 4D. Now with the CT, it is like the guided missiles, very accurate and very precise, and the errors are much less. So here are the two fathers, that is the Navinsi Nanda and Pigan Bam. And here I would like to say that the pathologists make the perfect diagnosis, alas, and late. they too late. Echocardiographer makes not so perfect diagnosis, but in time to save the precious life. And thank you very much for the kind and the patient hearing. I wish everyone a very, very bright and a happy Deepavali. Thank you very much.
Thank you, Madam. Professor Vijayalakshmi, Professor of Pediatric Cardiology at Sizar Institute. Now we thank you very much for a brilliant presentation. Now we proceed to second speaker, Dr. K. Sivakumar, Head Department of Pediatric Cardiology at Madras Medical Mission Hospital, Chennai. He has got 29 years of experience and successfully number of critical pediatric cases, and he has got 177 research papers. Now I would like to request Sir to share your screen and deliver your talk. Dr. K. Sivakumar. Thank you very much.
Thank you very much. It is a pleasure to meet you all, Professor Zahid Hossain, Professor Abdul Salam, and all the other friends. We just miss the nice sweets that you offer us when we reach Dhaka. And it is also a pleasure to follow one of our teacher, Dr. Vijayalakshmi. We will be talking about echocardiographic assessment before and after device closures. So I'll go step by step on diseases. Atrial septal defects, 80% of them are secondum and 10% of them are sinus venosus. These are the two that are amenable for intervention. Secondum ASD, we need to identify the size.
Would you please share your screen?
Is it not shared already?
No, sir.
No, sir.
Okay, sir. Okay. Okay, sir. Now it is okay.
Thank you very much.
No,
So-
no, sir. Again, it is disappeared.
Yeah, it
Right,
came
sir.
again.
Right.
Yes.
But once I go on full screen mode, you are not seeing that?
No, sir.
Is it okay?
Okay. Right, sir.
Yes. Right. It's okay.
Yes, we can see, sir. We can see now.
Thank you.
It is
Now
okay.
it is.
It is okay, right?
Okay, thank you very much. Sorry. Secondum ASD, we have to identify the size, the margins. We have to. Is it okay?
Okay.
Yes, sir. Yes, sir.
Okay. Then the 3D view from right atrium, we have to identify what about multiple defects and have some echocardiographic guidance during the procedure. So to understand what are the margins, this is the 3D en-face view of the secondum ASD on a cartoon and on a live 3D. And if you cut from the apical four-chamber view, we get the antero-inferior mitral margin and the postero-superior margin. If you cut from the parasternal short axis view, we get the antero-superior retroaortic margin and the postero-inferior margin. And if you cut from the subxiphoid view, we get the superior and inferior margin. The same way, if you do a transesophageal echocardiography, on a horizontal plane, you get the anterior and posterior margins. And if it is a 45-degree view, you get the antero-superior aortic margin and the postero-inferior margin. And in a 90-degree view, you see the superior margin and the inferior margin. So based on these margins and the size, you choose the device and decide about the suitability. Role of three-dimensional echocardiography is it gives the 3D en-face view, but you have to understand that the 3D images need a thick atrial septum. So a thin and floppy aneurysmal septum will not be seen clearly. Echo gains will need to be adjusted to prevent false dropouts. This is a false dropout, and multiple ASDs are understood better on a 3D echocardiography. So this is the three-dimensional en-face view, cropped up 3D echo views. Especially it is useful in multiple ASD. This is an ASD where there is a main large defect and a small additional very posterior defect. These posterior additional defects can be ignored. But if there are 2 or 3 defects that are pretty close to each other, then employing three-dimensional echocardiography will show an orientation between the 2 defects, and these can be closed with a single device. And if you have more than 2 or 3 color dropouts, then again 3D echocardiography is going to show better. These are 3 defects seen within the fossa ovalis. Interventional closure will depend on the location and number of the defects. It depends on the margins, the size. Very often we go for a device size of 2 to 4 millimeters more than the size that is measured on the echocardiography, and we get intra-procedural guidance. This is an intra-procedural guidance that we are getting with the left atrial disc seen in the LA, a balloon-assisted technique where the balloon is inflated, and this is preventing the left atrial disc from prolapsing into the right atrium. And we can also assess during a wiggle whether we are stable or not. This is a Minnesota wiggle that is being performed, and the device is actually jumping into the left atrium from the cable, indicating that it is unstable in position. And we need to get a very stable position on the wiggle where the device is secure, and this is extremely important. We need to look at all the margins. This is an impending device embolization. You can appreciate that the inferior margin, the posterior margin has slipped off, resulting in a residual color flow. And these are devices, if we are not capturing immediately, will go for embolization shortly. Coming to patent foramen ovale, it may be associated with the atrial septal aneurysms. Atrial septal aneurysms are defined as septal excursions of more than 15 millimeters and the base of the aneurysm more than 10 millimeters with a high risk of thromboembolism. We can appreciate a large atrial septal aneurysm with multiple color flows. And the most important thing is documentation of a right to left shunt.
Hello, sir. Kindly move your slides, sir.
Is it not moving?
No. Yes, no, sir.
No, only one slide. First slide, what you have shown, that is we are seeing.
Oh, so you have not been seeing any slides at all so far?
No, Sivakumar. We are seeing only the first slide.
First slide, yes.
Sivakumar, I think you can.
Yes.
Go to this screen share.
Go to slideshow.
That's right.
This is, now slide has changed.
No.
We are not seeing anything.
Now you can go presentation mode.
Are you seeing the?
Yes, right now.
Now it's okay, I think.
What I am showing is a contrast echocardiogram from filling the right atrium and right ventricle, an atrial septal aneurysm. Is it the same slide that you are seeing?
No. It's okay.
No, sir. I need to know what you are seeing there. Is it a right to left contrast flows through the PFO?
Yes.
Okay, so this is the contrast that is spilling into the left atrium here and the atrial septal aneurysm, and these are the patients where we go for device closure. And in PFO, balloon sizing is done during the procedure because the PFOs are extremely stretchable. Sometimes we may puncture the septum rather than going through the PFO to achieve a device closure. Now coming to sinus venosus defects, let me again reconfirm. Are you seeing the images?
Now the slide is sinus venosus defect.
Thank you very much, Dr. Nakaruma. So sinus venosus ASDs are another new recent intervention. This is a superior form of sinus venosus ASD where the superior vena cava enters the right atrium and the left atrium here. You can see the left-right shunt. So in these patients, the first step is a balloon occlusion, wherein you occlude the SVC RA junction with the balloon and inject into the right upper pulmonary vein, and the right upper pulmonary vein drains entirely into the left atrium here without filling the right atrium, indicating that the sinus venosus ASD is getting closed. And so after a covered stent implantation, this is a catheter in the right upper pulmonary vein, and you see that the right upper pulmonary vein fills only the left atrium without filling the right atrium. And this is understood by transesophageal echocardiography. This is the echocardiography with the sinus venosus ASD stent in place. There is no left-right shunt, what you saw a few slides before. And if you right toward torque, you will appreciate the right pulmonary vein completely going into the left atrium. Previously, this was actually entering into the superior vena cava. So coming to the next lesion, perimembranous VSD. Perimembranous VSDs are chosen depending on the proximity to the tricuspid valve and proximity to the aortic valve. We classify the perimembranous VSD as those with completely no aortic margin, those with a muscular aortic margin, those with septal aneurysm, and those with septal aneurysm that is formed by the septal tricuspid leaflet itself. So this is an example of a VSD with no aortic margin. Here you can appreciate the perimembranous VSD. There is no margin from the aorta. These VSDs are better closed by the older asymmetric device, which is nowadays not available from the AGA, but available from the other Chinese vendors. Type B is a condition where there is a good aortic margin. These are VSDs that are best closed either by a duct occluder or a muscular VSD device, depending on the size of the hole. Very large holes, it is better to use a muscular VSD device. The third type is membranous septal aneurysm, which is independent of the septal tricuspid leaflet. You can see the septal tricuspid leaflet separately and the membranous septal aneurysm. This is best closed by an ADO2 device. The last type is the type where septal tricuspid leaflet itself is forming the membranous septal aneurysm, and here a duct occluder is the better device. So perimembranous VSD, because of the proximity to aortic valve and the closeness to the aortic valve leaflets, we need to make a very careful assessment, and those who are already having a pre-existent prolapse of the aortic leaflets or grossly distorted tricuspid valve should not go in for VSD device closure. Coming to muscular VSDs are classified depending on whether they are anterior muscular or posterior muscular or mid-muscular. Most of the muscular VSDs are amenable for interventions. Coming to last, PDA, the anatomical criteria is looking at the size of the PDA. This is the ductal view. The ductal view is a left parasternal view with the probe kept in a sagittal position without any tilt. And what you see underneath the sternum will be, this is the sternal probe, and you see the right ventricular outflow tract continuing as the main pulmonary artery, and this is the ductus arteriosus. If you invert it like a V, which how we see on the transesophageal echo, this is the picture, and the corresponding image, this is the descending aorta, conical PDA with the pulmonary artery, and a continuous flow through the PDA is visualized here. Once you visualize that, then measure the ductus. So this is the ductus measured in supero-inferior direction. You can also do the same measurement in side-by-side direction on a short axis view. So this is the short axis view cartoon, and you can see the short axis view. You are again taking a measurement. Based on this measurement, then you choose the patient for device closure. In all these patients, you ensure that there is no posterior aortic shelf. And if there is a posterior aortic shelf, these patients may get coarctation after the device is in place. So most PDAs today are closed in the cath lab. PDAs are closed 2 millimeters more than the size that is measured on echocardiography with the device. We should take care to exclude posterior aortic shelf. Last lesion, AP window, restrictive small to moderate sized AP windows can be closed. So this is the aorta and the pulmonary artery. Here you can appreciate the AP window, which is an intermediate form of AP window, which is away from the aortic valve and the pulmonary valve. You can appreciate the color flow from the aorta into the pulmonary artery. And here you take the measurement between the edges of the AP window, and these are also amenable for device closures. Now, points to note in AP window is that only we should choose restrictive AP windows. Very large non-restrictive AP windows are not amenable for closure. Measure the diameter on echocardiography. Ensure that there is a good distance from the aortic valve, pulmonary valve, and the pulmonary artery origins. Either it can be closed by ADO1 type of device or ADO2 types of devices. The other shunts that I have not covered in this presentation are ruptured sinus of Valsalva aneurysm, coronary arteriovenous fistulas, aorto-right atrial and aorto-right ventricular tunnels, and all the postoperative residual shunts. Now coming to what are the anatomical criteria for any shunt lesions. Now in this period of corona, they say mask, mask, and mask. Similarly, the criteria for any shunt lesion suitability for an intervention is echo, echo, and echo. If you have a 3D echo, utilize them also. Choose the device depending on each morphology, and choose the catheter strategy if the safety is much better than surgical outcomes. Thank you very much for your attention. Am I audible, sir?
Yes.
Very much audible and visual also. It was nice.
Thank you, madam.
Thank you very much, Dr. Sivakumar, sir, for your brilliant presentation. And we thoroughly enjoy your talk. Now we proceed to the third speaker, which is well-known pediatric cardiologist, Dr. Amitabha Chattopadhyay. He is currently working at Jamshedpur Narayana Multi-Speciality Hospital and senior consultant at Narayana Super Specialty Hospital, Calcutta, and Robinath Thakur International Institute of Cardiac Science, also working in Narayana Multi-Specialty Hospital, Bangalore. He is especially adept in device closure, ASD, VSD, PDA, valvuloplasty, and coarctoplasty. He holds an experience in 24 years in medical field. He has more than 11 publications in national and international journal. Now I would like to request sir to share your screen and deliver your talk. Thank you very much.
Good evening, everyone. Am I audible?
Yeah. Yes, sir, you are audible.
Yeah. Good evening, everyone. Thank you for the kind introduction. It's indeed a great honor to talk after two of the doyens, Madam Vijayalakshmi and Dr. Sivakumar, who have given a brilliant speech on on echocardiography during interventions. Incidentally, Dr. Sivakumar's and my talk will be slightly overlapping, but I'll try to delete some of the slides which are really overlapping and will be disturbing. My topic is role of echocardiography in interventions. So I've chosen a few ones like a balloon atrial septicemia for the sake of the postgraduates and the fellows. The balloon atrial septicemia, what is the role of the echocardiogram? First of all, you have to be slightly ambidextrous, and the fellow who is the most ambidextrous in the whole unit gets a chance to show echocardiography during a balloon atrial septicemia, because he or she has to stand on the contralateral side to the operator. Usually the operator stands on the right side of the baby, and the other person stands on the left side of the baby because they have to show with the left hand. So there has to be some amount of ambidextrosity present, and the person has to be accustomed to that one. Also, sterility is a big part in this one because the area where the echocardiography will be done and the area where the, where through the Bass catheter and everything in the groin are in a very close proximity, hence it has to be absolutely sterile procedure. First of all, you have to assess the PFO, which is a restrictive one in this particular case, and you have to assess whether your catheter has actually crossed the PFO. So by the echocardiogram, we assess that one. We assess the flow across. In this particular example, it's a bidirectional flow, which is the truth. And thereafter, the catheter has actually crossed the PFO and it has gone beyond it. So we have to make sure that it has not gone inside the left atrial appendage, because if we inflate the balloon inside the left atrial appendage, then it might rupture or it might cause some injury. So the balloon has to be inflated inside the left atrium proper to the submaximal point. Here it has entered almost in the left atrial appendage, so it has to be retrieved slightly. So upon the direction of the echocardiographer, we have to do that one. Now the balloon has been inflated and pulled across the PFO, thereby causing the flap. So the success of a BAS represents on when the echocardiographer calls out that there has been a nice flap and there has been a good flow across a good unrestricted flow across the PFO, and or rather an ASD now with the nice flap you can see with the nice flow, and obviously the saturation is increased. As you can see, the flow has increased and the saturation has also increased. So this is the criteria. The second one in my case is a ductal stenting. So Dr. Sivakumar is a doyen in this one. So here you can see a pulmonary atresia with the transposed right arteries, and the pulmonary atresia is membranous one, and the duct is supplying the pulmonary circulation. As you can see, the ductal flow is coming here, hitting the membranous pulmonary atresia membrane, and it is going back with this blue flow. Here, what are the assessments we should be doing? Echography. Where here we should assess how the duct is arising, so that it depends on, it is imperative that we take the access accordingly. For example, some of the ducts may be approached from the groin, while some of the ducts may be approached from the left axillary or the right axillary. Here you can see that the duct is actually facing the left axillary. So we might as well take the left axillary approach, and the things, the whole task will be very, very easier if we take the left axillary approach. And also the length of the duct and the course of the duct has to be measured, whereby we can assess that what is the length of the stent which has to be used, and obviously it also depends on what is the diameter of the stent which we'll be using. Here we assess the diameter of the duct at the pulmonary end, which will be the most constricted part, and the length of the duct. Here you can see that the duct has been stented, and obviously the flow in the duct is now being seen. Here you can assess the duct has been stented and the flow in the duct is now assessed, whereby we can see that the stent is across. There will be no visible thrombus or anything inside it, and here you can assess that the flow inside the duct is totally patent, and that there is good flow through both the branch pulmonary arteries, which will help the branch pulmonary arteries to grow. The third case is the atrial septal defect. So Dr. Sivakumar has very nicely described the ASD assessment. So I'll directly go to a very, very atypical ASD, which is probably the fifth case in the whole world to be reported. Actually, we are late in reporting that one. This is a coronary sinus ASD, and it's unique in its assessment, where you can see there is a gap at the roof of the coronary sinus. So it is an interchangeable term, whether it is an unroofed coronary sinus or a coronary sinus ASD. this is one of our unique case whereby you can see there is almost a 10 to 11 millimeter coronary sinus ASD, and there was volume overload of the right atrium, and you can see there is a gap inside at the roof of the coronary sinus with a flow inside. So here we have assessed there is the flow through the ASD, and it is flowing from the left atrium through the coronary sinus to the right atrium, and it's a coronary sinus ASD causing a right atrial volume overload. Hence, we decided to close it. This is a TE equivalent. You can see that the coronary sinus has a rent at the roof, and you can see that this is a coronary sinus ASD. And we went through the usual approach like from the IVC, but this time we went through this is the coronary sinus, which is a dilated one, and often the left superior vena cava is patent, which is an advantage actually. So we had put two catheters. One was the left superior vena cava, and the similar one we went through the coronary sinus and through the roof of it and placed our catheter in the left lower pulmonary vein, and thereby the two discs have been released across the ASD. As you can see, there is no leak, and the left at the same time the LSBC was patent and it was not obstructed. So thereby, as in the assessment, we have seen plenty of ASDs in the regular positions, but I thought this would show it. This one of our fellows later, when the patient came for a follow-up, had actually reported the device had dislodged and was lying on the roof and the floor of the left atrium. You have to know that this is a coronary sinus ASD which has been closed with the device, which was a 12 millimeter device, and it was perfectly sitting. There was no obstruction to the coronary sinus, no obstruction to any of the pulmonary veins. And later on, we did a CT scan. This was a 3D echocardiogram which showed that there was no obstruction anywhere, and this was a CT scan showing there was no obstruction to any of the pulmonary veins. How do you assess the VSDs? These are regular ones which Dr. Sivakumar has already shown. This is how a perimeter's VSD would look like. And we have to tilt our echo probe to a little bit towards the tricuspid valve to assess the perimeter's VSDs in a parasternal long axis. And this is a perimeter's VSD as such, whereby you can assess whether it is guarded by the septal aneurysm formation. This is a perimeter's VSD with an RCC prolapse. So we would have very reserved view about this device closure. Perimeter's VSD with an RCC prolapse. RCC is totally prolapsed, and one of the walls of the VSD is actually made up by the RCC. So we would not venture into device closures in these cases. Yeah. And this is an inlet VSD. So there is absolute contraindication. These are the cases we should avoid. This is an inlet VSD is subaortic extension. So this is a contraindication for device closures. This VSD is too large. It's a pre-op VSD basically. This is too large, and hence it would amount to septation of the whole septum. So better these kind of patients go for a single ventricle repair. This is a large VSD is the pre-op, and I will show two of the post-operative videos as well, as I thought that the pediatric cardiologist should also know how the post-operative echo should show. This is a pre-operative VSD. This is a large one, so we do not go for a device closure. This is a post-operative patient. As you can see, there is a huge VSD closed, and there is a flap inside. Sometimes the flap the VSD, there is a small residual VSD across it, and the flap might cause some RVOT or LVOT obstruction. This is the muscular VSD, apical muscular VSD, which is amenable for a device closure, but the approach has to be different. It has to come from the internal jugular vein so that it forms a straight and allows you to actually close the VSD. This is the same muscular VSD. Here we measure in another different view, which is the device closure perimeter's VSD with an aneurysm formation, and we'll show you some horrific incidents as well. We were lucky, or rather unlucky, to record these ones. This is a live ASD device dislodgement where during the assessment the ASD device actually slipped. So there are some of the horrific experiences we also had. And this is the PDA device. While we were assessing the device, no one actually thought so. It was an unstable device, as Dr. Sivakumar was describing in one of his slides. The device actually slipped and went inside the right pulmonary artery. So this was some of the horrific incidents which we had shared. Thank you very much.
Thank you very much, Dr. Amitabha Chattopadhyay, for your nice presentation. Now, to the purpose of our Echo Summit, to connect ourselves to the national and international echocardiologist, echocardiographer for the learn knowledge regarding the modality of echocardiography and echocardiographic assessment in the clinical disease. Now, at this stage, I would like to hand over to Dr. Jafrin Jahan for the question and answer segment of this session. Thank you very much.
Thank you. The presentations were excellent as usual. Due to time constraint, I am inviting only one question from the audience.
Can I add something, Japin Jahan, as a chairperson?
Yes, sir, of course.
Thank you, BHC, Bangladesh Society of Echocardiography. This is the session dedicated to interventional cardiology, like us people. And I miss in this time the presentation. Every year, the BD intervention gave a lecture to me, the role of echocardiography in intervention. But in this time, I think it's anyhow it's missed or due to time constraint. Three speakers, very renowned. Vijayalakshmi madam is very close to me. Then Sivakumar is very several times visit our institute RSCBD, and I talked with him and also did lot of support in the pediatrics department. And Amitabha's lecture was very good. But we are the people who do the intervention, like some role of echocardiography, some TAVI, and also some optimization of CRT, heart failure treatment, CRT implantation. I think, I don't know, in other session it will cover, or this is the dedicated session for intervention cardiologists. I think these two from morning I'm seeing the session, the role of intervention in the TAVI. Is there any role of echocardiography, TAVI or TAVA, or particularly CRT implantation, optimization, pre-patient selection and post-optimization? Still there is role. Still there is no role of echocardiography, I think. Though it is not nowadays not recommended in the recent guideline, but though the implanter use it, I think I request Vijayalakshmi madam to say something about the.
Yeah, I just want to add one thing. A good cardiologist is the one who is a good clinician, the basic clinics, and a good interventionist is the one who knows good echocardiography. Because unless you have a clinical acumen, you don't make the diagnosis. Unless you assess echocardiographically, your success rate will not be high. So my success rate
so that madam, I appreciate your presentation. It is very good quotation, ma'am. Your last slide shows a good quotation.
Thank you, madam.
এখন তুমি কেয়া তো নহল দিনে কি হয় না মিলাদুন নবী কেয়া
এটাকে মিউট করে দাও তো কে কথা বলছে দেখি
2000 কে আর দিবিনি ওবিডিয়ার মাইনিয়োগ
Japin unmute. This is the session is closed. My session 5 is closed. Or you are going to other session. Japin, unmute yourself. Unmute yourself. Japin, unmute yourself.
Hello.
Dr. Japin.
I think, sir, there is a technical problem.
Please conclude the session. Please conclude the session, sir.
Okay.
Speaker was very nice, brilliant presentation was there. Our fellows and our young cardiologists, including interventional cardiologists, will be beneficial from their lecture. And thank you for participating our country's international conference, virtual conference on echocardiography. Thank you.
Thank you.